Yes. Good afternoon, everyone. And today's class will be on CA stomach, and it's also called as gastric carcinoma. Shall we go into the class? And gastric carcinoma, it can be divided into benign and malignant lesions. Benign lesions are epithelial and mesenchymal, and the malignant lesions are primary a constitute adenocarcinoma, cyst, and lymphoma, and secondary. Secondaries include invasion from the adjacent tumors. And the definition for gastric carcinoma, malignant lesion of the stomach, which occupies mostly in the antrum of the stomach and which always accounts to about 60% of the cancers of stomach. And epidemiology and risk factors. 55-year-old Japanese man who is living in Japan and working in the industry. It can occur at any age, but the peak incidence is 50 and 70 years old. It is more aggressive in younger ages and twice more common in males than in females. Japan has the world's highest record of gastric cancer, and it can be attributed to many reasons like nuclear explosion and also food habits, and also Japan has the highest cure and also the recurrence rate is very low. Studies has confirmed the incidence decline of Japanese immigrations to America. Dust ingestion from variety of industrial process may be a risk. Incidence of gastric carcinoma, Japan 70 in 1 lakh per year. Europe has 40 in 1 lakh population per year, and UK of 50 in 1 lakh population per year. USA 10 in 1 lakh population per year. It's and it is decreasing worldwide due to advanced modes of diagnosis and also the treatment. Risk factors for gastric carcinoma. The predisposing factors are pernicious anemia. It can cause atrophic gastritis, previously resected gastric ulcer like chronic duodenal ulcer which has been for cicatrization and doing a anti-AGJ or a post-AGJ, smoking, alcohol, and the environmental factors like H. pylori infection. Most of the patients will have H. pylori infection, and it also predisposes to a CA stomach. And low economic status, as mentioned earlier, from Japan, and also diet. And diet rich in vitamin A also prevents the things. And in terms of genetic, there is blood group A, which has higher predisposition for gastric carcinoma, and HNPCC. And clinical presentation. Most patients, why are there in advanced stages? Mostly gastric cancers are silent and they are often asymptomatic at early presentation. The common clinical presentation will be loss of appetite and loss of weight for more than 10 kgs in 4 months. And the patient will have noticed an epigastric discomfort and postprandial fullness. This presents to the emergency department complaining of vomiting and also large quantities of undigested food and epigastric distension. And this is termed as dyspepsia, epigastric discomfort and postprandial fullness. And common other presentation may be an epigastric pain, bloating, early satiety, vomiting, nausea, dysphagia, anorexia, weight loss, and also sometimes if the lesion is more advanced, the patient may present with hematomesis, melena, and also with iron deficiency anemia, cerebrovascular iron deficiency anemia. Signs like anemia, weight loss, epigastric mass, hepatomegaly, ascites, jaundice, blue muscle, Gustav notes, sister Mary Joseph nodule, and also the patient may have some Prinberg's tumor, which is just the peritoneal deposition of CA stomach to the ovary, and also Irish lymph nodes, that is the left supraclavicular lymph node. And classification are termed as into Lawrence classifications as interstitial carcinoma, stomach and diffuse carcinoma. Stomach and third is mixed morphology. Interstitial carcinoma, it arises in the areas of intestinal metaplasia to form polypoidal masses or ulcers. And diffuse gastric carcinoma, it infiltrates deeply in the stomach without forming obvious mass lesions but spreads widely in the gastric wall, and it leads to linitis plastica, or otherwise it is called as leather bottom stomach, and it carries much more worse prognosis, and it usually spreads through the muscular and the mucosal layer. And other morphology may be a polypoidal or a ulcerative or a superficial spreading ulcer or a linitis plastica. Early gastric carcinoma, which is limited to the mucosa and submucosa without lymph node involvement, that is T1 lesion without any lymph node, and the full curative rate is 5 years. Survival will be about to 90%. And in advanced gastric carcinoma, it involves a muscular dysplasia, or it has four types of in the Borman's classification. Type 3 and type 4 are not fully treatable, both surgical as well as chemotherapeutic and radiotherapeutic. Staging of gastric carcinoma. T1, where there is invasion into the lamina propria and the submucosa. T2, it involves only the submuscular layer, and the T3 involves the serosa layer, and the T4 it involves the extra serosal and also extra peritoneal structures. And lymph node. Lymph node N1 will be an epigastric lymph node, N2 will be a main arterial lymph node, and metastasis. Spread of gastric carcinoma. It has major four means of spread, that is direct spread, lymphatic spread, blood-borne metastasis, and also the transperitoneal spread. Direct spread. The tumor usually penetrates the mucosa, serosa, and also the adjacent organs like pancreas, colon, and the liver. Lymphatic spread. What is the most important node will be a Bishop node or the left supraclavicular node, or maybe the Crozius and blood-borne metastasis. Usually the extension disease where the liver is first involved, then the lung and the bone. Transperitoneal spread. There is always transperitoneal spread which may lead to ascites or to the ovaries, which is also called as Kuchenbeck's tumor, or to the umbilicus, which is called as system Mary Joseph nodule. And the complications, and it may be a parietal and extraparietal. Parietal, it may be a peritoneal or a pleural effusion. Peritoneal, it leads to always ascites, obstruction of the gastric outlet, which leads to vomiting and also various metabolic complications like achlorhydria, and patient may be having loss of potassium and loss of sodium, and or a small bowel obstruction, or you can or bleeding ulcers, or intrahepatic jaundice by hepatomegaly. The intrahepatic jaundice by hepatomegaly is due to involvement of porta hepatis nodes, which is very bad prognostic factors, and the cause of jaundice in carcinoma stomach may be due to liver metastasis or a extrahepatic portal obstruction due to enlargement of the porta hepatis nodes. Differential diagnosis. It can be a gastric ulcer. It can be other gastric neoplasms, gastritis, or a gastric polyp, more likely a Crohn's disease. From the history, cancer is not ruled by antacid, not periodically, and not ruled by eating or vomiting. Investigations, we'll be doing a full CBC, LFT amylase like this, and serum tumor markers CA72 buff4, CEA, CA1919, which are not specific. Stool examination for apple blood, and chest X-ray and bone scan for metastasis. Specific investigations like UGScopy and with biopsy, double contrast study, CT scan, MRI, and endoscopic ultrasound, and also diagnostic laparoscopy. Esophagogastroduodenoscopy. This is a keen investigation to see, and also the diagnostic choice for carcinoma stomach and other lesions in the stomach which can be ruled out. And the diagnostic accuracy is up to 98%, and 6 to 7 biopsies are taken to rule out the stomach, and the biopsies are taken at each margin to see the edge, and also the biopsy is taken at the margin of the ulcer, not at the center of the ulcer, and also a double contrast upper GI X-ray which is also diagnostic, and it mostly helps in full linitis plastica and also in gastric lymphoma, where your UGScopy cannot pick up any ulcers or it cannot pick up any lesions. So the gap, as the lesion will be in the muscular propria layer. So the mucosa and the submucosa, which is seen in the gastroesophageal scopy, will be normal, which can be and this states that early superficial gastric mucosal lesion can be missed, and it cannot be differentiated between a benign ulcer or ulcerating adenocarcinoma of the stomach. You can see the benign gastric ulcer, X-ray showing symmetrical radiation because of folds by histology, no evidence of malignancy was observed. And this shows an X-ray shows showing an extensive involvement of the fundus and cardia. And this slide shows the pyloric and also the antral constriction and stenosis of the pylorus as a chronic duodenal or a chronic ulcer in the pre-pyloric region. CT and MRI, which helps in the assessment of wall thickness and metastasis in the peritoneum, liver, and also the lymph nodes around the stomach. Laparoscopy, mostly a diagnostic laparoscopy to detect any peritoneal metastasis, where only a palliative or some or a minimal bypass surgery is needed for the patient, where there may be a full peritoneal metastasis, and the patient will not be a suitable candidate for any resection. And this is the CT images where you can see involvement of the nodes and also the stomach showing an hypertrophy lesions, and UGI, which is the which is a very gold standard investigation for seeing any gastric mass or any gastric ulcer, for which you can do a biopsy. This shows an ulcer of size, which is shown here, and some food sediments and the mucosa of the stomach, which is not maintained. This shows in the antral region, mostly suggestive of an ulcer, and the biopsy should be taken from these sites and also from the edges or the corners of the ulcer. UJ scopy, we can see an ulcer mostly 50 to 25% of the times, and also some polypoid mass or a superficial spreading ulcer or an infiltrative ulcer which is not seen, or which cannot be seen or which cannot be detected in a UGI. Accuracy is 50 to 95%, and it depends upon the cross appearance, size, location, and the number of biopsies. And seeing the ulcer, that it may be a benign or a malignant ulcer, and there can be some round to oval concave lesions with straight walls or smooth, flat bases. And also, a malignant ulcer will show a full necrotic and also a hemorrhagic outline, and it is fully irregular. Smooth margins with normal surrounding mucosa, and also some irregular and raised margins, mostly on the lesser curvature or benign lesion. Anywhere, malignant lesion can occur anywhere. And earlier they used to say that if there is any malignant lesion in the antrum, it is considered as malignancy. Now, anywhere in the stomach, any lesion, it can be considered malignancy unless otherwise proved. Majority of the benign ulcers are less than 2 centimeters in size, but malignant ulcer, there is no any cutoff like that. Normal adjacent rugae folds that extends to the margin, and the adjacent rugae folds may be prominent and it is edematous as shown in the previous picture. And this is a benign gastric ulcer and also malignant gastric ulcer. Benign gastric ulcer shows even margins and not a punched out and full regular margins without any excoriation. And a malignant ulcer shows lot of excoriation and also lifted up and also elevated rugae, which which is so pathognomonic of a malignant gastric ulcer. This is a ulcer where you can see the rugae folds which are converging at the point of ulcer, and this is the malignant ulcer. You can see an irregular surface, a lot of necrotic debris, and biopsy should be taken from the edges of the ulcer. And the management may be surgical, chemotherapeutic, and also sometimes it can be a radiotherapeutic. Chemotherapeutic and radiotherapeutic agents are not proven with any other surgical benefit. It only prolongs the life. And the initial treatment is to improve the full nutrition of the patient by parenteral or enteral feeding, and to correct the fluid and also the electrolyte imbalance. Anemia, if it is present. Most of the patients will be having silent anemia at the time of presentation, and it should be improved in the course of time in the hospital. Any patients, mostly they will be in old age, and status improvement of the patient is very essential in the initial treatment. And also the preoperative care staging is important because we are not subjected to patient radical surgery which cannot help them. And the preoperative care as follows. Types. There are three types of gastric surgery. One will be a total and a subtotal and a palliative. Total gastrectomy is done for proximal gastric lesions, and for arterial disease, a subtotal gastrectomy. And arterial disease, mostly we go for a subtotal gastrectomy. Mid body and proximal lesions, we go for a total gastrectomy. And now the concept of total radical surgeries has been given up. And now sometimes we used to do an extensive resection and to remove the stomach distal part of the esophagus and the proximal part of the duodenum at the D1 junction or with the lesser and the greater momentum along with the lymph nodes. Esophagogastrojejunostomy with also U and Y reconstruction. That is done for total gastrectomy. This is the picture for showing total gastrectomy. This is the esophago sorry, and this is the also this is the which is showing total gastrectomy where there is anastomosis of the duodenum with the esophagus, and also the second part of the duodenum is retained and the first part is transected, and which ensures a complete bile drainage without obscuring the pancreas and also this. And subtotal gastrectomy. This is similar to total one, except the proximal part of the stomach is preserved, followed by a full reconstruction and also making an anastomosis by gastrojejunostomy, mostly a Billroth tool. Subtotal gastrectomy. This is the subtotal gastrectomy. Here the proximal part of the stomach is preserved, and the margins for subtotal gastrectomy will be 2 centimeter beneath the distal margin and proximal 5 centimeter above the margin. This will be the margins for subtotal gastrectomy along with the gastrojejunostomy. And other types of reconstruction may be a gastrojejunostomy or a U1Y reconstruction, which usually prevents the bile reflux. And also palliative surgeries for patient with advanced and inoperable cases who is having symptoms of obstruction or bleeding. Palliative gastrectomy is not really necessary to be radical, and to remove the resectable masses and also reconstruct anastomosis, intubation and stenting, and also recanalization can be used. And this is the picture showing a palliative bypass for a distal gastric cancer, which is involving the antrum of the stomach. So the ulcer has invaded the posterior structures and also the advancement of the stage. So we are doing only a gastrojejunal anastomosis and a gastrojejunal bypass to relieve the obstruction of the patient. And post-operative disorders, the patient is admitted mostly in ICU, and detailed nutrition assessment along with Dumping syndrome, and it has to be fully evaluated. Post-operative complications may be a leakage from the duodenal stump, secondary hemorrhage, and also the nutritional deficiency in long term. And chemotherapy. Chemotherapy mostly ensures the long survival of the patient in spite of the good disease. And mostly used regimen is Marcenian regimen. There is epirubicin, cisplatin, and 5-fluorouracil for 3 weeks for 6 cycles, and the response rate is only 40%. And radiotherapy, post-operative radiotherapy may decrease the recurrence, which is also. And in chemotherapy, there may be a neoadjuvant chemotherapy and also an adjuvant chemotherapy. Neoadjuvant chemotherapy, which is given usually before the surgery, there will be 3 to 4 cycles of neoadjuvant chemotherapy, followed by 4 to 6 cycles of adjuvant chemotherapy, so that the resection uh, of the tumor may be possible, and also doing a D1 or a D2 resection. D1 resection is doing until 1 to 6 group of lymph nodes, and from 6 to 12 it will be under D2 resection. Most of the surgeons are practicing only a palliative D1 resection, and also the palliative resection is not approved nowadays, and it should be resected from 1 to 6 group of nodes for D1 resection and D2 resection from 6 to 12. That means the survival of benefit for D1 and D2 resection. D2 resection has more good survival rate, and also there is proper clearance of the surgery, and also the tumor margins are well preserved, and there is very less recurrence rate when compared to D1 resection. And D3 resection, and the resection of the and the resection of the uh, all the retroperitoneal group of lymph nodes and also the adjacent lymph nodes are being deferred now. And a D2 section and D3 section has not much survival rate when compared to D3 resection. D2 and D3 resection, D2 resection holds good. D3 resection there is lot of complication, and also patient may have least survival rate when compared to D2 resection, and which is mostly done in European and also in some Korean and also in some Japanese hospitals. And prevention, diet, more vitamin A and vitamin E supplements along with fruits and vegetables. Possible some carotenoids, as said, vitamin A, it's whole green cells and green tea, smoking cessation, and cessation of alcohol intake. Early diagnosis remains a key in this problem. So the gastric cancers are so silent. And staging of the disease. Example of staging of gastric carcinoma. Stage 1, there is 95% survival, where there is T1, N0, and M0. And in T1 lesion and with N1 metastasis, the survival, the 5-year survival rate is 70 to 80%. And in T2 lesion and with N1 lesion, the survival is 45 to 50%. When the lesion is above the serosal layer or it is in the subserosal layer along with lymph nodes involvement, the survival will be from 15 to 25%. This survival can be improved on the basis of chemotherapy and the radiotherapy, and also getting a good resectable margin. And in any metastasis, the 5-year survival rate will be only less than 10%. Important factors which also influence in the survival of full resectable gastric cancer allows to be the depth of the invasion and the presence or absence of lymph node, regional lymph node, which improves the 5-year survival rate. That is 10% in all US states and also 50% in Japan. In Japan, most of the 5-year survival rate is more than other countries. It is due to the early diagnosis and also use of lethal resection, and also for early gastric carcinoma, there will be screening and also endoscopic mucosal resection, endoscopic submucosal resection, which is followed in Japan and also in other Korean countries. Now, other gastric carcinomas are just gastrointestinal stromal tumors, and it is also previously known as leiomyoma and leiomyosarcoma, which is less than 1%. And also, rarely it causes bleeding and obstruction. The origin of cyst will be from the interstitial cells of vagina or the full autonomic nervous system cells. The full distinction between benign and malignant lesion is unclear. In general terms, the larger the tumor and greater the mitotic activity, the more likely to be the metastasis. The stomach is the most common site of cyst, and it is usually fully undiscovered in endoscopy and in radiography. The endoscopic biopsies may be ununiform because of overlying mucosa is usually normal, and it is only in the muscular plane. Small tumors, they can go for wedge resection, and large ones will go for gastrectomy. Gastric lymphomas. Gastric lymphomas, the most common primary GI lymphoma. It is usually increasing in nature, and presentation similar to gastric carcinoma may reveal peripheral adenopathy, abdominal mass, or splenomegaly. Diagnosis is usually by EGD scopy, and also a full contrast GI X-ray or a CT guided 5 needle aspiration or an endoscopic ultrasound to see the level of invasion. Treatment is usually surgery. Surgery can be a subtotal or a total gastrectomy, or with splenectomy for palliative resection, or a full adjuvant radio or a chemotherapy, which improves the 5-year survival rate. And most of the gastric lymphomas are due to T11 and T18 translocation, and also KRAS gene translocation. Most of the gastric lymphomas are associated with H. pylori infection. So the gastric lymphomas with H. pylori infection has a very good prognosis, has a very good prognostic rate than gastric lymphomas with H. pylori negative thing. and thank you for the class.